them. Had apologies for that. We had originally scheduled this and then realized that we needed to adjust the time because of daylight saving time and other issues. And we thought that we had adjusted it, but for some reason, for some people, it got changed back to the original time. So we apologize for that. I know that many people got lots of emails that they didn't need to get, and others got emails that they didn't want to get, but we did the best we could given the circumstances and the technology. So let me just go ahead and introduce this session today. So this is the Hospital Data Forum, and this is our kickoff meeting for the virtual version of the Hospital Data Forum. The Hospital Data Forum is part of the Hospital Data Initiative, and I'll explain that in just a second as well. And this is all sponsored by NADO, the National Association of Health Data Organizations. And I think most of you are familiar with NADO, who we are and what we do, so I will be brief, but I think there's some who may not be. So NADO is a national nonprofit membership and educational association dedicated to improving healthcare data collection and use. That's what we do, is we improve healthcare data collection and use. We have members and partners that include state and private health data organizations that maintain statewide healthcare databases, and of course, many stakeholders related to those databases as well. So if you are not a NADO member and would be interested in learning more, just ping me. I'm happy to talk about that anytime. So NADO and hospital data, it's almost synonymous. Our history is the same as the history of collection of hospital data. We are committed to supporting all of our members and anybody literally who is participating in the collecting of discharge data from hospitals and other facilities, such as data on hospitalizations, emergency department data, ambulatory surgical data, and I think some of our members have gone into other areas as well, such as behavioral health, et cetera. So this is all part of hospital data collection. And our history puts us back to 1986 when we were founded, in the very beginning of when these types of efforts were organized. And our activities over that long period of time, almost 40 years, have made significant improvements in the quality and utility of hospital data, including the collection and standardization of data so that would facilitate data being populated into the HCUP project. And we are seeking always, but especially this year, to add support for the growing needs of the hospital data collection and use that's happening around the country. So that's part of the setup. So now I want to talk about the Hospital Data Initiative. This is a new initiative for NADO, and it is intended to exactly do that, add value to our current members that are operating hospital discharge or other data programs, supporting those systems, and of course, the users of that data as well. There are three main areas of focus that are part of the initiative: the Hospital Data Forum, which we are doing today, the creation of educational materials, which we will talk a little bit more about later, and then increased collaboration and coordination with HRQ's HCUP project. So where are we today? Today we are at the Hospital Data Forum. And the purpose of this data forum is quite simply to facilitate the sharing of ideas and networking. We really want it to be a forum where people can come and speak with each other. We had in-person meetings of the Hospital Data Forum in 2023 in Boston and 2024 this year in New Orleans. And the general takeaway from those two meetings was that there was so much to talk about that we couldn't do it justice by just meeting together once a year. And so the request was for us to come up with a way to have quarterly meetings. So today is the first quarterly meeting. Save the date. I guess I could have taken that off because you've got it now. Our next meeting will be in February and also be virtual. We will have our annual in-person version of the Hospital Data Forum somewhere between May 6th and 8th, and that will be in Austin, Texas, as part of NADO's in-person annual event. And then again in August, and then we'll be back around to November and continuing on quarterly. Each Hospital Data Forum will have a short presentation on a topic of common interest, followed by interactions among participants. And hopefully this will give you a chance to ask questions from your colleagues and share best practices and learning. So to kind of get this kicked off, I went back and looked at what happened in Boston and New Orleans to give you some ideas of what were the topics that were discussed and how did things flow. So the presentation at the beginning was opening remarks by Pam Owens from HRQ. And then we spent a significant amount of time talking about hospital data quality issues, including the interplay of HDD and EHR, data linkage, the problems of growth, provider challenges, race and ethnicity data, and probably many other things that I didn't capture in the notes. Then we spent some time, as we typically focus on data quality and use cases. That seems to be the two things people want to talk about. So then we talked about what are some new or ideas for use cases for hospital data. And then emerging topics, behavioral health data as part of a hospital data program. And then how does hospital data tie back to equity? Those were the topics that we covered in Boston. In New Orleans, the topics were similar. The meeting was similar, but you'll notice some differences here. The welcome and introductions were done by Josie and Bichara from NORC. And then we had an interactive discussion with ARC about ARC's issues and what ARC is. And there was a fabulous conversation there. Then we talked about how to overcome data collection hurdles, just free flowing. What were the hurdles that people were experiencing with data collection? Then we talked again about use cases. How do we power insights and with hospital data use cases? And then finally, because we were at the networking sessions, there were other topics around us. What did we learn from those other topics and those other sessions that we could pull in to talk about the hospital data? All right, so with that, we are going to have our presentation today. First of all, I want this to be interactive. So if there are any questions, I don't guarantee that the chat function is on everyone's screens because Microsoft Teams is kind of funny that way. But if you have any questions, just go ahead and just take yourself off mute and I think we'll all be polite enough that you can just say, I've got a question, and then I can pick one of the 2 or 3 people that speak up. We'll make sure everybody gets a chance to ask their question. So does anybody have any questions about the Hospital Data Forum, what we're trying to do today, and how this fits into our overall strategy?
Question. This is Ray.
Yeah, go ahead. Sure.
Will you be sending out recording of this?
Yes. So this meeting
Okay.
will be recorded, and the recording will be available to you or to anybody that missed it. Yes.
All
Good
right.
question.
Thank you. All right.
Thank you. Any other questions? All right. So with that, we are now going to have our presentation. We have Oscar Ibarra from Maryland HSCRC. Oscar, are you able to share your screen, or do you need me to do that for you?
Go ahead and do it, Norm.
Okay, hang on one second.
Yeah.
All right. Are you seeing it, Oscar? Maybe not.
Yes, I can see it. I can see it, Norm. Yes.
Okay. Great.
Okay,
Go ahead.
Myself, Oscar Ibarra, and Miss Claudine Williams, she's our director for our center, will be presenting the how we collect data in Maryland. Next slide, please. Oh, also, the Health Services Cost Review Commission is a state agency. We're part of the Department of Health here in Maryland. Next one, please.
As he's moving the slides, also just adding some color commentary, we also regulate hospitals. And so as part of our regulatory mandate, we collect hospital discharge data for the purpose of rate setting.
Yeah, thank you, Claudia.
Yes.
You able to move him, Norm? Or?
Yes, there we go.
Okay. The next slide is, let me
I think if you take it off enable editing, it'll forward.
Right, yeah, it might be
All right,
forward for there. No,
Yeah,
one more up.
this.
Just one more.
Like that?
Yeah. Yeah, this is a summary about Maryland. Population about 6 million. 16% is above the age of 65. Maryland has the median household income, the highest by the state. We regulate 56 hospitals. 43 of those are private, non-for-profit acute care hospitals. 2 academic medical centers, that's the University of Maryland and Johns Hopkins. 8 freestanding medical facilities. 4 psychiatric hospitals, and 1 children's hospital. Total revenue for calendar year 23 was about 21 billion. And recently we signed an agreement with CMMI to be in the first cohort of the AHEAD model. Just a little facts about Maryland. A small state and very populated, as you can see. Next one, Nora. Okay. Case mix is just discharge data that we get from the hospitals. It is necessary for methodologies here at the Commission. One of those is the market shift. The market shift data set includes inpatient and outpatient variables that are processed through the 3M, not the 3M, the Solventum APR DRG groupers. It is used for the development of the market shift adjustment, which in turn provides the criteria to relocate funding to account for shifts in cases between regulated hospitals. We also have trend tables. They compare utilization from year to year, both calendar year and fiscal year, as well as year to date. The MHEC, or the Maryland Hospital Acquired Conditions, it is aimed to reduce the number of PPCs, so potential preventable complications, through individual hospitals, and statewide rewards and penalties. Claudine, if you have an input, please jump in. This program, the MHEC, is similar to the federal Medicare program. The RRRP, the readmission reduction incentive, it was implemented to reduce preventable 30-day hospital readmissions in the all-payer model, and is closely aligned with the federal readmissions program. Hospitals can receive rewards or be assessed penalties based on readmission rates. We also have something called the CDSA reports. This is an innovative drug funding for hospitals. It was implemented back in 2016, right, Claudine? Something about that. It is a schedule that measures volume and charges in the use of certain high-cost physician-administered outpatient drugs, mostly oncology and infusion drugs. The expectation from the hospitals is they use this information to correct errors before they submit the data to the Commission. And there could be fines for the hospitals if errors are found in this report.
So just to add a couple of things before we leave this slide. So I saw some questions about Solventum. So 3M had changed their name to Solventum. So these are the 3M groupers that most folks are aware of. There's a couple of other, okay, I think that's a separate question. So there's a couple of other use cases that we use our case mix data for. Our hospital discharge data, particularly our race and ethnicity data, we did a lot of work to ensure that its accuracy. So because of its high accuracy, those data elements are shared with some of our state partners, particularly Medicaid, as well as our state HIE, CRISP. And they are used for their reporting, as well as population health reporting dashboards that we do for other state agencies within Maryland. So these are a few of our other use cases of case mix. All right, next slide. And I think
are you up or I'm up?
Well, I can do this.
Okay, thank you.
Yeah, so a few of our data innovations in Maryland, like I was indicating before, we have worked very closely with our state designated health information exchange, the HIE, which is CRISP, for a lot of our regulatory reporting, as well as more public-facing population health reporting. And they work very closely with us on the master patient index. So that master patient index, the unique identifier that links all of our case mix data, but then it also links it to the APCD data that MHCC, our sister agency, is in charge of, as well as Medicaid data and data that we get from Medicare. So that master patient index also gave us the ability to do the RIP program, the readmission program, as without that, we would not have been able to link across hospitals. So one of the other things that we're very proud of in terms of our data is our routine auditing. So we audit all of our case mix data. We audit about 12 hospitals a year, as well as doing targeted audits for particular issues that we find in case mix. So we are constantly ensuring that the data that comes in and impacts our downstream analyses as well as methodologies is reliable and valid. And then we also have the ability to collect data elements almost on the fly. So because our regulation allows us to collect pretty much any variable that we need for rate setting purposes or for the model, which we mentioned earlier, the AHEAD model. And prior to that, it was the total cost of care and all payer models. You know, we can add additional reporting within like, you know, a few months. So a good example is that we perform poorly on ED length of stay and ED wait time. So we started a whole initiative last year to it's interesting because I'm trying to present and then I'm seeing the questions. But anyway, so we were rated fairly badly on ED length of time. So we started this initiative as well as there was some legislative push to really do some, or to address it, to track it, and to see if we can make an impact. So we immediately within, I would say 4 to 6 months, implemented a data collection feed to get ED length of stay data. And so just our ability and our agility to collect data when we need it, I think is one of the benefits of our data hospital discharge data program. So next slide. So another data innovation I wanted to mention is the electronic clinical quality measure. So we, back in March of 2022, CMS put out a digital quality measurement strategic roadmap to try to get folks within 7 years to achieve full digital quality measurement enterprise. So we are halfway there. Beginning in June of 2022, Maryland became the first state in the country to successfully begin receiving digital quality measures from all Maryland regulated hospitals. So we have started collecting on a fairly regular basis. We're trying to do it quarterly. Some hospitals are more successful than others on submitting quarterly, but we are getting a regular feed from all Maryland hospitals for all patients, not just Medicare patients, but all patients. And there are a few quality measures that we're tracking: hyper and hypoglycemia. We're monitoring that. Obstetric morbidity and C-section rates is also being monitored. We're also using it for all payer readmission and mortality measures. And we'll start collecting all payer core clinical data elements for the 30-day hospital-wide readmission, I think, and the hospital-wide mortality. So that's also in the pipeline. So all of these are currently being monitored with the potential of having public reporting and adoption into our payment models in the future. So we are definitely on the forefront when it comes to that new type of data. So I'm going to pause here to see if there's any questions. I haven't looked in the chat, so I don't know what's happening over there. Okay, I think they're still talking about 3M. Okay, so next slide. So some of our progress and challenges in data collection. So some of our progress that we've made, I would say in the last 5 to 10 years, we've streamlined our hospital discharge data collection. We've worked really hard with our current data processing vendor, H-Metrics, to, oh, Norm, you have a question? Oh, you're on mute. Still on mute.
Just keep going. Just keep going.
Oh, Okay. So we worked really hard with our data processing vendor Hmetrics to streamline particularly the way that hospitals receive their their error reports and their edit checks. Everything is a web-based portal. So once they submit data, their error reports are available on this portal, as well as all of their submissions. So we can track their submissions as well as them. They also submit requests for extensions, and they have the ability to skip on a monthly report. We have hospitals report monthly, so they report preliminary data on a monthly basis, and then every quarter we do a final close, which is 60 days after the end of the quarter. So for these monthly submissions, hospitals have the ability to skip a month as long as they can report the next month, and then they'll catch up. And then for quarterly submissions, they can only request an extension. So all of that has been automated and put into a portal. So it's a much easier process to request these types of information. We're centralizing, this actually happened in the past month. We've begun to centralize our financial and discharge data with that one vendor of Hmetrics. So we're pulling in a lot of financial data that was being submitted through various means and it manually tracked. So all of this will be centralized in a web-based portal, as well as outsourcing a lot of the production of most of our data sets. So at one point we were getting raw data files and then having to produce internally a lot of downstream analyses, downstream data sets for analyses by the staff. And that was a total time suck and taking away a lot of valuable time that we can use for investigating various issues with our data. So when we brought on this new data processing vendor, we were able to outsource a lot of the production of data sets so we can focus on more downstream analysis and auditing of that information. So some of the challenges that we are still working through, like I mentioned, modernizing the financial data collection feeds to, have it more aligned with our hospital discharge data, proactively finding and resolving data issues. And, I'm sure everyone has the same issues where, you think your data is fine until somebody who's doing some downstream analysis find an issue, and then you have to find the issue, rerun things, and so forth and so on. So we are trying to find ways, and I'm, definitely interested in hearing what other states are doing and what other organizations are doing to proactively get at certain data issues. Also, our data is still being submitted via flat file, so that's a very antiquated way of doing things. However, it takes there would be an enormous infrastructure lift on our part to really transition to a more updated file format. So that's something that we can look to do in the next couple of years now that we have kind of everything centralized with the data processing vendor. That's one of the things that we'd like to investigate as part of that contract. And then also finally incorporating other clinical and clearinghouse data for the AHEAD model. So since the AHEAD model is not about it's just about hospital discharge, and we really need to have insight into providers that are outside of the hospital, to ensure that we're not just looking at just Medicare data, which is really our only insight to providers outside the hospital. So bolstering our data feeds for these other sites and these other providers will give us a more, complete picture of the total cost of care in Maryland. So that's our slides. I will pause here for any other questions, and Norm, you can take over.
Let's have you go ahead and either type questions in the chat or raise your hand. come on, there's this many people, somebody's got to have a question somewhere. Well, the presentation was great, but it wasn't perfect.
I don't take offense to that.
You can't get everything in a 10-minute. There we go. Generosa, go ahead.
Hi, thank you for a great presentation. I'd like to know, what products do you produce for downstream for the others to use that you're talking about?
So it can vary. So we produce internal patient level data sets for, like, say, our quality programs to monitor the readmission programs, or our methodology team works a lot with one of the things that Oscar talked about was the market shifts. So looking at service shifts between hospitals to ensure that they're the money that follows the patient. So if it needs to be taken from one hospital to another because those patients have moved to another facility. So those are a handful of things that we do, but then we also produce analytical files for the public and also for other state agencies within within Maryland. So for our health departments who are looking for utilization of certain hospitals, or looking at the prevalence of certain diseases versus researchers who are interested in, a particular, chronic disease or whatever. So there's a lot of different downstream use cases for the data.
Okay, we have a question from Betty in the chat. What types of checks or edits happen upon submission?
So we do a laundry list of edit checks. So there's variable level, then there's cross variable level. Now that we're getting our financial data feed in there, there's the opportunity to do some more cross checks with a different data set. The financial data is based on admissions, while the case mix data is based on discharge. So there is a difference, but the magnitude should be relatively the same. So this is a great opportunity to include other data sets into our edit check programs. But we have a fairly robust edit check that we have about 100 plus variables, and there's literally an edit check for every one of them.
Okay, great. Chandrika asks, is your data shared with other programs?
Other programs within Maryland, yes. We also, so we share the confidential data with, say, like Medicaid. They get a quarterly feed of our data. We share it with CRISP. The HIE gets a monthly feed to update their regulatory reports as well as their public health reports. And then we also share it with, like I said, other researchers. Those are usually non-confidential final data, so we share them on an annual basis. So yeah, we have a whole process, a data request process that we've been doing for, oh my goodness, long as I've been here, for 17 years and much longer than that. So it's a fairly robust process.
And we share with HCAP too.
Yes.
There
Thank
you
you.
go.
Thank you.
Yes, share it with HCAP.
There you go.
Carrie Ann asked, does 3M support case mix adjustment of both inpatient and outpatient data?
So we do our internal adjustments. So we use the 3M products to kind of group them, put them in APR DRGs or whatever. We calculate our internal weights based on the charges of Maryland. So we don't necessarily use the weights that are with 3M. And any case mix adjustments we do, based on our own methodologies.
Okay, fantastic. Great questions. And thank you everyone for pitching in. We got one more.
I said one other
Yeah,
comment. So for the outpatient, we use EAPGs. And then for the inpatient, we use APRGs. So that's how we're able to, do both. Sorry.
Okay, so Pragya is going to ask a question that is one of our hallmark questions. What's been your experience with patient identification and making sure that they are unique? How well do you think it's going? What struggles do you still continue to face? And what solutions or suggestions do you have for others?
So we have been doing, we started doing the Master Patient Index, we call it the EID, since 2012. And so we made it part of our regulatory, a regulatory requirement to send the necessary information to create these patient EIDs, as we call it, to CRISP. So initially it took some time. It took us maybe about a year, year and a half to really get hospitals on board and clean the data. We require, and it's been a minute since I looked at those EID reports, but I think we require a 95%, correct me if I'm wrong, Oscar, percent match rate. Is that right?
That's correct. Yeah, 95.
Yes, 95% every month. So every time that hospitals submit their case mix data, H-Metrics and CRISP matches it up. And if the percentage is below 95%, we go back to the hospital and find out why it's not below 95%. And then we have them either resubmit the data that creates the EID, which is usually 9 times out of 10. And then CRISP and H-Metrics has an internal process to review EIDs to ensure that they are correct. So even if for that 5% that's not correct, they do manual and additional reviews to try to link them to a patient. So for the most part, we don't have concerns with the EID. Like I said, I haven't looked at our EID reports by hospital in probably like a good 5 years. Just even though we run them, but just because it's been fairly consistent over the long term, and our vendors, if it ever dropped below, they notify us and then we go after the hospitals. And plus the hospitals have a benefit to ensure that data is correct as possible, because, you know, the information that they give to us is used for our methodologies. And if those linkages are not correct, they stand to lose some money. So it's really, really important that is a really critical data element that we ensure that's clean.
Okay, and we got one last, two questions came in just at the same time. Narissa asked, how many hospitals do you collect from in Maryland, and what percentage of them are problem submitters, if you care to characterize them as such?
Let me look. Oh, so we collect data from actually 60 facilities, but we only regulate 56. We collect data, inpatient data, from 4 rehab hospitals. And because most of their payers are commercial, then once they hit a certain threshold, then we have to regulate them. But since they are underneath that threshold, then we don't. But we still collect their data to kind of ensure that they meet that criteria. In terms, so we get data on a monthly basis from all of these facilities. And like I said, there are sometimes, like for instance, if a hospital is going through an EHR conversion or whatever, they might have some data issues. They can request to skip. But for the most part, we, like last month, we got everybody's data. In terms of problem children, I would say that it's the smaller rehab hospitals. Sometimes when we do updates, they're not quite as sophisticated, or they don't have the bandwidth, or the staffing to ensure that all those changes are done in a timely manner. So sometimes they lag a little, but they're not our critical hospitals. And so for our critical hospitals, it is in their best interest to submit data every month, because we're constantly monitoring, we're constantly tracking, plus they get the data back through regulatory reports, and that's how they monitor their progress on like the MHACs or in any of the quality programs. So it's in their interest to submit data. So did I answer the question about
Yeah, let's hang on for just a second, because I want to make sure that we have time for launching our inaugural meeting. We'll hang on to that one. We'll come back to that one if we get a minute. But since this is our first time and we've got 150 people, which is astounding. Charles and I had kind of not bets, but we had estimated how many people we thought. I said, I'm super positive. I think we'll have 150. And I thought I was just being crazy. And he thought, we'll never get anywhere near that many. But here you all are. Makes it a little challenge for me to moderate 150 people, but I think we can do it. But let me ask the first question then. We want to ask this to everybody. Just put in the chat, what are the types of data collection issues that you are facing today? And we're not going to have time to address all of them and get you answers for all of those, but that will help us to set our agenda for future meetings. So let's ask that first question. What are the data collection issues that plague you today, that give you problems, keep you up at night, however you want to think about that? Just drop those in the chat. And that could be anything from missing data, incomplete data, fields that you'd really like to get that you don't get, any of the above, all of that sort of thing. There we go. So like hospital coding inconsistencies, billing practices that are inconsistent. And if somebody says something that resonates to you, just hit the like underneath it. You don't have to type it again. Just click on that like, and then we'll know that that's a problem for you too. Intensity and detailed understanding of outpatient data. Yeah, in fact, that's an interesting question. This is about hospital data, which is obviously inpatient data, and some of you are collecting outpatient data as well. So we're going to have some conversations later about what types of data everyone is collecting, but not right now. The decrease in the collection of Social Security numbers. In fact, Claudine, while these answers are coming in, could you just comment just briefly, do you currently collect Social Security numbers? Is that gone for you, or do you still get some of those?
So no, we don't collect Social Security numbers anymore. We did a fairly detailed cleanup. Oh God, I think probably when we started with the EID back in 2012, we sent out a memo and say, please don't send us, because some of the hospitals were using Social Security numbers, but I think maybe we were getting maybe 1 or 2 hospitals. So probably by 12, 13, most 90% of our hospitals stopped using Social Security number. And since we have the EID, we don't need it.
Okay. So the fact that you had created the EID in advance, thought about this coming down the road, has saved you from the real problems of it. If you were starting today, it would be a problem, right? If you're starting from scratch, creating EIDs would be a lot harder now. Okay, very good. Let's see what else is coming in here. High staff turnover at facilities makes contact and enforcement difficult. I remember that happening to me when I was in charge of our hospital data program. We are sending letters and letters and letters and emails and phone calls. This person never responded. After about 6 months, we sent a fine notice to the CEO, and they said, what is this all about? And we told them, I said, oh, that person hasn't been here for 9 months. Like, no wonder they weren't responding to you. So we did get the problem solved, but that is a problem. Longitudinally tracking neonate morbidity related to family member, mother, father health status, identifying specific locations with all of the consolidation that's going on. Yeah, I remember that as an issue as well, that you get an issue. There are certain hospital systems that don't do a great job of specifying the location, which exact facility is it? It's just the system. Race and ethnicity, missing race and ethnicity data. Yep. Yeah, Mel, I am curious about the we're going to have to get more information from Maryland about the generation of the EID, how they do it without Social Security numbers. Assessing outpatient subcategory spending, working with facilities that are unable to submit 837. Multiple vendors do not interpret 837 the same way. 42 CFR Part 2. Yep, that is an unknown and ongoing issue. Payer identification. Clearly, yep. And then Chandrika, representing the state cancer registry, challenging to recover data from physician offices. So implementing the APC Solve and Help Us and other programs. Maybe Oscar, Claudine, since that question came up, and this, I'll just maybe let anybody else as well. The question about the relationship of your hospital data to your all-payer claims database. I know Maryland has some relationship with your APCD people. What vision do you have for what that could be in the future? How well is it going?
So we actually get a regular feed from MHCC, their APCD data. We get it on, I think, a quarterly basis, if I remember correctly. And so it's linked via the EID. So then we can basically compare like our hospital discharge data and, see if those are also showing up in the APCD. It's fairly, the APCD isn't the universe. So there's not going to be a complete match, but I think it's fairly close. We've started using it for some of the analysis that we do internally, looking at deregulation, looking at I forget, this is not in my center that's doing it. But there is some analyses and some work that's being done using the APCD in conjunction with our hospital discharge data. But in terms of moving forward, I think we want to include more of the universe in terms of our APCD. We're looking to see if we can get clearinghouse data so we can kind of fill in those gaps. So that's kind of our long-term vision. So we're working with MHCC on that piece. I don't know if Ken or one of his team is on.
Yeah, and then so Brian from CHIA in Massachusetts, we've worked on analysis that we presented last week at NADO, where we were linked case mix and APCD data using a similar patient identifier. Had much success with it. If there are any other APCDs out there, Maine, Virginia, I've seen a few of you online. If anybody else wants to just chime in that you have something to add, that would be fine. And then I'm going to ask my next question. The next question is what this has to do with sharing your successes now. So I allowed you to share your concerns. Now we're going to ask you to share your successes. What is the best example of using hospital data that you all have come up with? Let's just put these in the chat. Type in the most creative thing that you think you have done using hospital data. So use cases or any opportunity that has come from your hospital data. So we'll give you a second to think about that, but we do want to have that one. Let me just check on my screen and see if I can randomly call people out, because I think I can. I know there are people on here who have done some creative things. Who do I dare call out that they won't be mad at me forever? Well, Kenley is on here. Kenley can't be mad at me because she's my boss. So Kenley, why don't you tell us that you're the most interesting thing you've seen people do using hospital data?
Thanks, Norm. Okay, so here at ACHI, at the Arkansas Center for Health Improvement, we have two big data solutions. One is called the Health Data Initiative, and it is solely dedicated to health policy support. You cannot sell data from it. You cannot give data away. It is for ACHI to do reports for the legislature. And the other is our all-payer claims database under the Healthcare Transparency Initiative. And I bring those two up because we get a copy of all of the Arkansas hospital discharge data for the health policy database. And we just get, for the APCD under the Healthcare Transparency Initiative, we just get the hospital data that is flagged as self-pay and uninsured. So we've done lots of things with the hospital data for health policy about costs and mostly workforce, and when Medicaid expansion hit, which hospitals survived and which didn't. But what we do with it, with the hospital discharge data and emergency department data, on the other side, is that we can use that data as a proxy for the uninsured and the self-pay, because our data solutions don't get data from, say, Walmart or Tyson Chicken, the big hitters, right, of self-insured plans. So we are able to utilize the data with analytic magic to represent the uninsured in our study populations.
And that's why all those people went to all that fancy statistical schooling, so they could do statistical magic.
That's exactly right.
I see Herb Wong has joined us from ARC. Herb, would you be willing to turn your mic on and just share a couple of thoughts about what you think the value of hospital data is or can be in terms of use cases, or whatever you want to say about why this is such a wonderful thing to keep doing?
Yeah, so a couple of points. So I work for the Agency for Healthcare Research and Quality. So it's largely a funding organization, but we also produce databases that we release back to the public for the purposes of generating evidence for to inform policy overall. So, the data set, HCUP has been the Healthcare Cost and Utilization Project, which we get hospital discharge data from all our state partners, has been ongoing since the 1990s. So not only do we have the ability to release those databases for public use, I think that one of the more important roles that it plays is actually in departmental policy. And I'll give you a concrete example. Back in the days when COVID hit, the HHS, the Department for Health and Human Services, was hungry for information to help inform the policies that were shaping along the lines with the pandemic. And one of the things that they turned to was to the HCUP databases, where we were able to provide them with information about ventilator use. And because we had the universe of hospital discharge data from all our partners, we were able to give them information along those lines. So I think that the fact that hospital discharge data is so incredibly well developed, and with a partnership with it like HCUP, you have a trusted entity such as AHRQ that can provide information to inform policy. So I think that is one of the greater values of this particular database.
Thank you. Thank you. I also noticed in the chat that Sylvia from Massachusetts says she can give an example as well. So Sylvia, if you want to pop on screen and give us your example.
Yes, the Massachusetts Department of Public Health Office of Emergency Medical Services used the outpatient emergency department data length of stay to analyze whether there was a pattern in patients who were boarded in the emergency department for longer than 24 hours and an increase in inpatient deaths. And they did see that impact, which resulted in ambulances being diverted. And using that evidence that boarding was associated with inpatient deaths, they outlawed boarding patients for longer than 24 hours to reduce ambulance diversions.
Great, thank you. Thank you so much. All right, we've got so many fabulous comments in the chat here. We've got about 10 minutes left. The last thing that I wanted to do again, and this has been fabulous because I really like the interactive way we've been able to do this, even with so many people, you're still able to get comments to each other. I want to hear from you. How do I put this? So for our February meeting coming up, I want you to tell me, yes, we will publish the questions and comments here with the video. Yes, we will figure out how to do that. Microsoft Teams is not my strong suit, but I know that that the video gets captured, and we will make sure that everybody who is interested gets to see it. Yes. So for the February meeting, we'll need to know what you want to talk about. We will again do the same format, have a presentation. We'll have some time for you to interact with each other. But maybe what I should do then for this last 10 minutes is people have raised lots and lots of challenges that they're having with data quality. And since we do have Claudine and Oscar still here, I maybe have them just comment quick. There was one question we didn't get answered, and then Mel asked about the generation of the EID. Maybe just give us a little bit more background on what goes into the EID. But first, let's answer that other question, it's way up here now. It's been pushed way up to the top. That was, wow. Do you remember what it was, Claudine?
It was something about newborns. I thought
matching newborns to moms. Yeah, I know this is a difficult challenge in hospital data as well, because newborns lack identifying information. They often lack names and things like that. Do you have problems matching the newborns back to the moms?
I remember we had this issue, and I see Shule is on the phone, so maybe she remembers how we dealt with it. I thought we excluded the newborns because they usually have the same medical record as the mom. And so when we were applying the EIDs, we had that same problem where we would end up with the same number. So for some reason, I'm thinking that we excluded them from EIDs, but I'm going to find out and I can email you, Norm. the official
Yeah,
methodology.
fantastic.
I don't remember off the top of my head. It's been a while since we crossed that bridge, and I know we adjusted. I just can't remember how.
All right, so it's like the generation of the ID. So it's a new person shows up in Maryland, goes to the hospital. Maybe it's me, maybe I've moved to Maryland. What goes into generating an EID for me as a new Marylander?
So once you come into the hospital, your patient information, like your name, your address, phone numbers are used to link social security number. If it's provided to the hospital, they can provide it to Chris, but it's not necessary. I think it's name, middle name, address, and phone number is what they use to match. And then they have a whole like program that they include all these pieces in, and then it creates the EID. What I can do, we have a document when we first came, when we put this into place with the methodology. I can share that with you because again, it's been like a couple of years since I looked at it. But that's essentially the very, very, very high level process. And then again, there are some manual pieces to it if the matching doesn't happen. So if the matching, if it's like you came in, but then someone who has your same name, your similar address or whatever comes in and it looks like, but your ages are different, that will go into a separate queue where a staff person will dig more deeply into that information and make a determination as to whether that person is actually, you know, norm or norm number 2, and be given a different number.
All right, and I'm going to pop my version of doing a survey question in here. I'm going to put a question in the chat, and if it's a yes, use the thumbs up, and if it's a no, use the surprise face. That kind of looks like a no. And the question is, we have committed from now till February to develop educational materials. And the very first thing that we want to do is to create an explainer video or recorded presentation to help just an orientation for people who are new to hospital data, and have that ready for you. It's just kind of our first bit of information in February of 2025. And then we will show that as part of, well, we won't be able to show the whole thing because I anticipate it'll probably be about 45 minutes long. Is that something that would be useful to you and to your organizations? It looks like several of you are yes. I haven't had any no's yet. All right. And then if you are interested in helping us develop that, if that's something that you would just like to be part of, just drop us an email just at info@nato.org and let us know. I think it's going to be pretty straightforward with as many experts as we have out there. It's just a question of compiling and bringing that information together as something that's a shared resources that everybody could use. All right, we are getting to the end of our time. Thank you to Claudine and Oscar for being our highlighted guest speakers. In fact, now I'm thinking that maybe that's just going to be the model, is that we will pick a hospital data organization, do a short introductory presentation, then have you be with me for the whole meeting to answer all the questions. It's been fantastic to have you with us today.
Happy to do it. Thank you for inviting us.
Yes.
Thank you,
So
Norm.
would not membership be required to view the material? That is a great question, and I am not prepared to answer that today because we have not crossed that bridge just yet. But it would it'd be easier if you were a member. That would make my life easier. But if not, we can talk. We'll have that conversation with you. Thank you, everyone. We will see you again in February. We are going to coordinate our date and time so that it doesn't conflict with the HCUP partners meeting. And then we're going to let you, once we have their date and time confirmed, we'll give you our date and time and we'll send out the invitation. So, oh, look at all the thank you. Oh, you guys are so nice. Thank you, everyone. This is fantastic. I'm just so glad to see a lot of familiar names and a lot of wonderful people.
Yeah.
And we will see you all in February. Thank you.
Thank you. Thank you, Norm, again. Thank you,
Thank you.
Claudine, for your help.
Thank you, Oscar. Bye.
Bye. Bye.